So here today with Dr. Brian Hutcheson. Brian is out in Florida, and I'm all the way on the west coast of Canada. And we're just going to have a conversation today about cervical instability and primarily upper cervical instability and the different means of treating and assessing it. And what got me really intrigued in wanting to talk to Brian is that he has personal experience in the regenerative therapies as it relates to ligament laxity and trying to get the ligaments to tighten up. And so, Brian, I appreciate you taking the time to talk about this. I have to tackle a lot of questions with respect to the different imaging modalities that one would use to diagnose this and the different treatment modalities. And one of the things that I don't have any personal experience in is the regenerative component. So I was, hoping that you could go through your own story as you suffered from instability that was relatively debilitating for you, and you underwent a myriad of things, and regenerative medicine being one of those. And I'd like you to just speak to that experience and I guess give me the different options that are available, and how they differ from each other.
Definitely. Thank you, Dr. Sasha. It's you and I have had a couple of chats together, and I love hearing your story as well, your persistence and just your commitment to not only dealing with cervical instability yourself, but your compassion for everyone going through it, and the amazing stories that I hear from people that go to your clinic and get great results. So thank you.
You bet.
My personal story started being young, playing sports, having a couple of concussions playing ice hockey, two car accidents that were notable where, I had such stiffness and spasms in my neck after that I'm sure that I experienced some not only micro tears in the tendons, but also some subfailure of the ligaments that maybe doesn't always show up on an MRI as a full thickness tear. But really, what I think is the general consensus, and people are becoming more and more aware of in today's age, in the middle of 2024, is that it's most often that symptomatic generation of pain that doesn't go away when you do regular physical therapy, regular chiropractic, take some medicine, is from the subfailure of connective tissue. So, the tendons and the ligaments get micro tears. They become a little bit frayed, and then almost the culture in that area changes, where it allows for abnormal nerve ingrowth and angiogenesis of blood vessels that aren't supposed to be inside of tendon or ligament, that start to protect your body in a way, but also stimulate an even worse and progressing cascade. They protect your body, Dr. Sasha, because I think that they tell it not to fire that muscle or not to use that area because it's weak and it can't withstand the force that it previously could. But then subsequently, because you're not using it correctly and you're activating other muscles when you should be using, your trapezius, it's using your SCM or whatever the cascade is that your body developed, is that over time, the muscle that was supposed to be used gets dehydrated and gets shortened, and it gets compressed, and then it starts to irritate surrounding tissue. One of the most common things I see is that the SCM gets completely hypertonic and it pinches right down on the carotid sheath. So it causes vagus nerve disorders, jugular vein compression, carotid artery, forcing blood to go faster to get into your head. And the list goes on. I mean, we could take this for any area, and the suboccipital and the vertebral artery connection, and then also lower in the body as well. In my
Brian,
individual
just
case,
one quick question for the people that are listening. Can you delineate the difference between subfailure and then a complete?
yeah, so subfailure may be something that doesn't even show up completely on an MRI, as it's a very small micro tear or breakdown in the tissue that causes it to lose its normal elasticity, its normal strength. And it's something that, an example that I give, Dr. Sasha, sometimes just to make it in simple term, would be that if you took a stretchy band, which I have one over on the other side of the room, I'll actually grab it because I really want to show this to you. And if I were to keep it close together, but if I poked a bunch of little holes in it, so I poked a bunch of little holes, you might not see them, but as soon as I stretched it like this, those holes would become much more visible. So it's almost what happens to the the integrity of the connective tissue is that at ease or at rest, you may not see it on an MRI, but once you challenge it to try to perform, is when it's going to expose that vulnerability or weakness.
Right.
So this is a big reason why you and I love to use digital motion X-ray. And even though on digital motion X-ray, we can't see connective tissue, we can get an idea of what's happening to that connective tissue based on how the bones move. And circling back kind of to my case, but still finishing your question, was almost everybody has some micro tears or subfailure of connective tissue at some place in their body. And we're fortunate if it's in an area that's asymptomatic or minimally symptomatic, meaning, well, if you strain yourself too hard, you get a little bit of knee pain, or if you really are working with your hands a lot, your wrists may hurt you a bit. But the area that we see that it causes the most neurologic dysfunction and catastrophic symptoms that can be debilitating is in the neck. And that's because of how important that area is. In upper cervical chiropractic world, the C1 and the Atlas, it's a connection between your brain and your body. It's at the base of where the brainstem becomes a spinal cord. But even more recently, I've been finding that another thing that we influence with the work we do is all of the connections between the heart and the brain. And so there's so much important neurology and circulation, blood vessels in that area that we're working to try to bring harmony with, and that's when people end up expressing health. You stop me if you wish, but I was going to jump into my case now.
Absolutely. Yeah, no, that's perfect. I
Okay.
just wanted to just sort of get around the notion of sub failure, which is not visible on imaging usually, but still leads to hypermobility slash instability depending on which part of the body you're talking about. So in the knee, you would have hypermobility causing a deficient knee, whereas in the upper cervical spine, you've got hypermobility. And if it starts compressing neurological structures pathologically, then you would deem it instability, and it's a serious issue. So yeah, that's wonderful.
Correct.
Thanks. Yeah, carry on with your story. I'm excited to hear that.
So mine progressed very slowly over time. When I first started to get some of those injuries, I was never, somebody that could make it into becoming a paid athlete. But I would say I was in really, really good shape, when I was 18 to 23. And so my musculature just allowed me to not express any symptoms. And then as I started to become a professional student in chiropractic school, sitting, reading for countless and endless hours, sitting in a white room just like this with almost nothing to distract me, I slowly started to feel like I had stiffness, I had tightness, there wasn't something quite right. And honestly, Dr. Sasha, this took probably about 7 years for it to slowly progress, despite managing it just with adjustments and working on exercise, where it progressed into daily needing a nap after lunch for 45 minutes, and then still by 4 or 5 p.m., starting to get brain fog, constipation, and feeling toxic. Where if I would try to, somebody that I always prize myself on my energy, I mean, I could go from 5 a.m. until 10 at night and feel amazing and do it every day of the week. And all of a sudden, by 4 or 5 p.m., I was feeling sick. If I tried to go out to dinner and have, a nice meal, one glass of wine with friends, I wouldn't be able to find the right words. I'd be saying things that weren't really too relevant. I'd feel crummy. It was really strange how the neurology started to affect me. I would get occasional sensitivity to sound. I definitely couldn't tolerate bright light as well. Now I'm back to, as you're going to hear what helped me. I mean, I can go out in the bright of day. I don't need sunglasses. I'm back to being able to fully function to, that 5 a.m. till 10 p.m. nonstop. Really, really good energy. But it was really scary and I didn't know what to do. And so I was just blessed. I think it was just one of those things you have to go through when you're being taught, part of your purpose or mission in life. Sometimes you go through it in order to be able to really experience it firsthand. And I feel really that this is a big purpose of mine, is to help bring light to some of these hard upper cervical conditions. And I just know it is because it feels right. It doesn't feel like work, even though I'm
Yeah,
working all the time. So I love it.
I
Um,
hear you.
So I started to, anyway, during the course of when my symptoms started, I actually serendipitously had purchased a digital motion X-ray. And, to make this not too long, the reason I got into it was a couple of my patients weren't fully healing. I went down the rabbit's hole as to why. I figured out it was likely instability, purchased a digital motion X-ray, got around all the smartest people that I could learn more about it, partnered with a regenerative medicine doctor in South Carolina, where I would do the digital motion X-ray, the chiropractic care. He would do the prolotherapy, PRP, and regenerative injections. And then ended up having the opportunity to work with somebody that's been doing regenerative medicine for 30 years. So I worked with Dr. Ross Hauser at Caring Medical for 2 years and learned a ton working there with him. And also, once again, just went down that path of what about the few people that this doesn't work for? It's been like an obsession of mine to try to find answers for those that fall through the cracks in healthcare. And we agree that healthcare does a very good job for a certain amount of people, but there's always somebody that falls through the cracks. And so I would say you and I probably try to help those people that often fall through the cracks. So I got 9 rounds, probably 8 or 9 rounds of regenerative injections to my neck, to shoulders, to different areas, a combination of both prolotherapy, sometimes PRP, other times. And at certain moments, like after a treatment, I maybe would feel up to 75% better, but it kind of settled back down at the 40 to 50% improvement. And I had extensive expert quality regenerative injection to the ligaments. And I went from having a 7 millimeter overhang to the left and a 5 millimeter overhang to the right to approximately a 5 millimeter overhang and a 3.5 millimeter.
Okay.
So I was getting better, but I felt like there was a missing link. And one thing that always helped me symptomatically, I could feel like a little bit of the constipation, a little bit of the brain fog starting. And if I put on certain types of standing weights that would optimize my curvature and help with some of the jugular vein drainage, I would feel like clarity come back. And I was like, okay, so I have got to figure out how can I get my body to stay here. And for me, through a combination of wearing the weights pretty religiously for several months, and then also through doing tendon dry needling, because the missing link was the tendons. I was getting the ligaments addressed, but I wasn't getting the tendons that also got degenerated, frayed, caused the cascade of shortening muscles, which kept causing me to pull my neck back into the wrong position and was putting excessive force back onto those ligaments when I wasn't in a good spinal curvature, which is probably why I only went from 7 millimeters to 5 after that many rounds, when typically you would have expected a little bit more stability in that many rounds of treatment.
Now, the prolotherapy versus the PRP versus the dry needling, tendon needling, and then obviously we have stem cells beyond that. But can you explain the differences between those modalities and I guess from a price standpoint and invasiveness standpoint and potentially even an efficacy standpoint, and when you're dealing with tendons or ligaments as far as the tissue sort?
That's an amazing question. And I've been waiting to answer this for months. So thank you so much for giving me that question. And so, first of all, I'm a chiropractic doctor and I'm not a regenerative medicine doctor, but working with it closely, I think that I have a pretty good opinion on it. And so I'll start first with the regenerative things that I do not offer. Prolotherapy uses dextrose, which is a sugar. And my understanding is that when it's injected into an area, it kind of kills off the first layer of cells, and that stimulates a regenerative healing effect. The body starts to go in and repair, and hopefully builds back a stronger connective tissue in that area. Which I've seen it work, many times, and it does a very good job when it's the right therapy, when it's indicated. PRP takes your own blood and it tries to make it really rich in the platelets, which are a big part of stimulating repair. And so I'll quickly dive over to the one that I do. So tendon dry needling, when done correctly, also causes blood to go to the area, which is going to have platelets in it. So it's going to give a effect of, a similar avenue of using blood to create healing. And, depending on when you get into, you would have to ask a regenerative medicine specialist, but there's all sorts of variables when it comes to these, and people have say, well, my PRP is better because, and my PRP is better. So there's a lot of little ways that you can optimize, how effective that it is. But I've also gotten PRP done, and I actually preferred it over the prolotherapy a little bit. I felt like it gave me a little bit better response just personally, but
Were
they
the
both
same
did.
were the same areas being addressed with the Prolo as
Yes,
well as, yeah, okay.
the same areas. And then some doctors will choose Prolo or PRP depending on the region. I think, of course, if you're treating like a meniscus or something like that, I think they usually go more towards PRP or using blood, and you wouldn't want to inject sugar or dextrose, I don't think, into that area.
Right.
But then the strongest regenerative agent known to man is right inside of our own body, and it's bone marrow. So some pretty skilled practitioners will actually pull bone marrow out of your leg or your hip, and then spin it correctly, and then re-inject it into tissue to bring a really profound regenerative cascade.
So the stem cells are one person's their own stem cells, yes?
So that, in from what I've learned, that would be the best way to do it. I mean, it's already your own body's healing ability, and then you're using that specifically to create more healing. There's a lot of other people that use, umbilical cord stem cells, or even stem cells, that are derived or made in different ways. I think a couple of things that are the gray area that some doctors, at some of the clinics that I've studied from, don't prefer is
Yeah.
you don't know how many of them are alive by the time it gets there. Um, there's a lot of variables you can't control, and then it's from a foreign tissue. So, but some people get good results with using those as well.
Now, and also I've noted that especially in my neck of the woods here, there's not a lot of options for practitioners who are willing to do Prolo or PRP at the C1-2 level. Can you address that from a standpoint of safety concern, experience concern? Because obviously the vertebral arteries are quite exposed there at the facets of C1, C2. But what is your experience in the sort of the likelihood of easily finding somebody who would address that area from a regenerative medicine standpoint?
It's a great question. So, just to finish up real quick, because there was one part I didn't ask.
Okay.
Typically, nationwide, I would say an average for getting prolotherapy to the neck would be anywhere from $800 without doing C1, C2, probably up to $2,000 for including the upper neck C1, C2. If you do PRP, I think that treatment ranges more from, this is just my opinion based on what I know, probably more from average of $1,200 without the upper neck up to maybe $5,000 or $6,000 if you also get PRP with the upper neck.
Mm-hmm.
Bone marrow treatments I've seen range anywhere from probably 3,000 to 4,000 upwards of 12,500 for one round or session of treatment. And then the tendon dry needling is usually anywhere between $200 to $500 per treatment. So that was one part that you asked me to just
Yes,
highlight or
thank you.
talk a little bit about. And then efficacy or things like that, it can vary greatly as far as where are you going to get the most bang for your buck or the most value. Because after all, we all are interested to first start with least invasive to most invasive, and then to be mindful of our spend. And if we can get the same result, I think most of us would be happy to spend less to get that same result.
And this is where the
So
DMX comes in handy because you know exactly where you're going and why.
yes, so precisely why you and I love to use digital motion X-ray, to be as precise as we can in how much instability do you have, because symptoms can vary. I mean, I've had people, and I'm sure you have, that only had a little bit of instability on DMX, but their symptoms were debilitating. I mean, they couldn't barely get off the couch,
Yeah.
and we were able to rehabilitate them back to functioning. And then you have other people that say, "Oh no, doc, I just got some neck pain, and if I look left, I feel kind of faint, but otherwise I'm fine." And we find they have 7 or 8 millimeters, and you're like, whoa, this is potentially going to get worse. We have to give you a real careful plan, and you're probably going to want to get some of these other therapies eventually to help you fully stabilize. So yeah, if you don't look, you don't know. And, if you can't see it, you can't treat it correctly. So digital motion X-ray has been life-changing for my practice. It's been absolutely amazing. But yeah, it's important to quantify those injuries. It's important to try to start with least invasive to most invasive, and to be mindful of cost when you're considering your approach.
Right.
The next question that you asked me that I was going to jump into, can you just reiterate that one again?
I think it was the concern of going up to C1, C2, because
Vertebral.
you alluded to the expense change between doing everything below that being an X number, and then when you include the upper cervical spine, it triples or quadruples in some cases. And just kind of touch on that because I know it's an area of higher risk and
Mhm.
potentially more efficacy if you can find somebody who's proficient in doing it and skilled and experienced.
Definitely. I think it's really important to address. I mean, if you know that you have C1, C2 instability, you have to address things that connect to C1 and C2. And so I always tell people start with just getting, working with somebody like you, work with an upper cervical chiropractor, try to do some gentle strengthening. If you've already exhausted all of those, which most of the people that come to see us, have already tried all of that, then you've already worked with, one of the tools that you've designed, and, they're getting some results, they're getting relief, but they still want more. They're like, okay, I'm considering, what kind of regenerative injections am I going to do to supplement this process and get even a little bit more stable. Um, I think that everybody, honestly, except for people that have such extreme instability, Doc, I think they should start with doing a little bit of tendon dry needling, because it's so easy to do and it's much less risky. And now, please don't misconstrue that. I don't want anybody to go find an acupuncture needle and just try to start doing it on your own. It's not easy to do, but relative to some of these high level procedures that doctors are doing, putting you to sleep, going through your mouth, targeting the alar and transverse. I mean, that's really high level and difficult and invasive and has to be done super careful. Or going posteriorly into the C0, C1 capsule. I mean, that's pretty, high level real estate where you've got things to avoid on many of the different sides. I would say C1, C2, people are starting to acknowledge that it's not as hard as they previously thought. You can kind of pretty quickly with ultrasound, you can find out where the vertebral artery is, and you can get into that. It shouldn't be seen as hard as it is by many of these brilliant and incredible hand-eye coordinated physiatrists and medical doctors that do physical medicine and rehabilitation. I think we'll see in the next several years more and more doctors that are taking that on, and not as they see how important it is for people. At this time, you still have to go to one of the clinics that has been doing it again and again and again and just has good results and continues to work on it. But if you contact the tendons that connect onto the C2 spinous process and then connect back up to the skull, those are very, if you go to a skilled person, very, not super invasive to work on. And you may find that you start feeling a lot more stable just from getting those muscles back online from stimulating the tendons.
So tell me, is there a difference? I mean, I've heard the term dry needling a lot, but I've not heard the term tendon dry needling per se. Are those different or are they the same thing, but I'm just hearing a new word?
Yeah, I guess it is. I'm going to say it's very different. Okay. So when I took dry needling, we learned how to stimulate a tendon or an enthesis, a connection point of a muscle onto the bone. But it was probably overlooked as far as I think how valuable that it is in these difficult cases. And really, tendinopathy or a tendon problem is 30% of all musculoskeletal diagnoses for people that go in to see their doctor nationwide. 30% of the time, they have some strain sprain, some tendinopathy, tendonitis, something along those lines. So it's a very common thing that's happening that nobody really has historically, I feel, addressed correctly. If you look on the literature, oh, well, we don't know if we can fully ever heal tendons. And I haven't done a lot of pre and post MRI, and I'm going to probably start doing more studies where I get really good ultrasound images of tendons in the beginning and work on them several times and then repeat it, because it'd be good to see but the people are getting the results. I mean, and
Now, is this
so
mainly because you're focusing on the suboccipital muscle group and as a specifically? Because I don't hear
well,
a lot of people telling me that they have practitioners, whether through IMS, dry needling, address that region. It's usually traps, levator,
yeah.
the larger group muscles, but not so much when, talking about C2 spinous.
So it could also be lower. So we know we have splenius cervicis connects from the upper back to the neck,
Yep.
capitis from the lower neck, upper back to the skull. You've got levator, C1 to C4. You have, the SCM, which connects from the mastoid. That's a really good one to work down to the sternum and the clavicle. There's a lot of, you have omohyoid, which, sometimes the scapula connection actually can
Yep.
be pulling and tugging on the neck and
Yep.
creating issues. The multifidi, you have, the rotators. So there's a lot of different tendons to think about and consider as to where you're going to get the most value early on, because sometimes people, that they're in this position and they're eventually going to need to get their suboccipitals worked. But if you only treat the suboccipitals, or if you only treat C1 ligamentously, but you don't first get them in a position where they can hold their head here, it's like taking a vitamin when your stomach can't absorb. It doesn't make any sense to me why people, I guess you're getting a little bit of benefit. You might absorb 5% of it, 10% of it, but hierarchically, whatever the word would be, you're going to want to first get your digestion on board before you take $100 special supplement. You're
Yeah.
going to first want to get yourself to be able to hold yourself in a reasonable posture before you're going to want to get that $10,000 injection to the C1 ligament. Because otherwise, if the reason that it gets bad is because there's an excessive force of a 10-pound head on a 2-ounce bone, and you're trying to get it better while it's in this position, it just seems, it doesn't make sense to me. Maybe my brain works weird, but it seems a little bit crazy to me.
Now, do you have the weights there? Like that you said you use the weights for because I think I've seen those on one of the Ross Hauser videos, but I've never actually looked up close to see what that
Yeah,
looks
I
like.
do. I can show you a couple. And when I say that, I just want to barely retrace to say when people have extreme instability, they often need to start with the deep ligaments and before they can start to improve their posture and curvature. So I did see cases where somebody's so extreme that they just need to get really good injections into the deep ligaments to start to be able to hold their head up a little bit. But in probably 80% or more of the cases, we want to try to get that head over the shoulders, I think, before you go into
Regenerative.
some of the deeper ligaments
Yeah.
to assimilate and to absorb and to really get the maximum benefit of that treatment. So I have a couple right here. I can show you. So these are a couple different weights. This one is one that I designed. It's called the Halo Hutcheson harness. And this one actually pulls the lower neck up. I got some good controversy for this one because I don't think anybody had ever designed anything that pulls the lower neck backward. So when I first started using it, how anything starts, you get a couple cases that were seemed like miracles, right? So I just took a traditional hood weight that hangs over here that Dr. Dennis Wogan first started using, I believe, that pulls your neck back like this to create the curve.
Yep.
And I took it and I figured out this one person, nothing was helping him. We were all working. We had regenerative doctor work and I was working on the person. And I folded the hood weight and I put it on this way. And I literally got a lady that was having to use a feeding tube and couldn't walk to all of a sudden be walking around the office. It was something. It was a sight. I mean, I put this on and what it was doing just on her, it worked. It was pulling the lower neck up in just the way that I had it hitting. It was primarily hitting the force out on the transverse process and a little bit in the middle, but there was a little crevice in here where it wasn't hitting her jugular vein. And so she had that on for a few minutes and then she could walk around the office and it was incredible. And that's when I got that spark. I'm like, there's something here. This needs to be looked at a little bit further in detail. And since then I designed one that's a little more specific where it has little cutouts that we're working to get just perfect, where it's going to mostly take pressure off and open up. So now after getting a little scrutiny, I got a couple of pretty big shots that were telling me, what are you're going to block the vessels. And I'm like, well, actually, I measure the internal jugular vein below the weight bilaterally and above the weight bilaterally, and make sure that it's larger in the standing position in all four, and there's color flow than when they didn't have it on. And then sometimes, depending, we can also check the vertebral artery, see how it's altering nerve and blood flow. Then next one is just it's called like chest weight with a cervical belt. So this one just goes on. You can put it at different levels depending. I might put foam pieces to raise it up, depending if we want it to go through C3, 4, 5, 6. And then this one, would be something where you'd let your neck kind of fall into to start to create a lordosis.
And you can wear that all day long, or how long would you wear that for?
No, it's just like, so you're retraining your neck when you're doing these. So
Yeah.
I tell people, how long would you train your chest for at the gym? And they say, oh, 20 minutes. And I'm like, yeah. So yeah, you know what I mean? You wouldn't, all day I'm just, still working the chest. And so, and your neck is smaller, it's not like huge. So typically we start people at 1 minute, 5 times a day, and graduate up to 3 minutes, 5 times a day. Usually like the 15-minute, 20-minute area is pretty good to, get everything to start to activate. Then there's different ones, there's, I just got back from San Diego last night. Actually, I was working on the Halo Hutcheson harness. I'm making version 2, which we're trying to get it. So 70% of the time that I have people wear it, it opens a blood flow above and below. 30% of the time, it only opens it in a couple. And one of them, it doesn't change it at all. So I'm trying to see how can I make maybe 2 sizes that just perfectly somehow gets the force a little bit here. So it would just affect your swallowing, but you can swallow. It's not like pushing very hard, it's just a few pounds. And mostly wraps on these TPs and pulls back. So I'm working on fine tuning it. Here's a halo weight, which just has weight on the front. And so you can put that flat across your head, and wearing one of these is going to fire your suboccipitals, because if you don't, your head's going to fall forward. So that'll help the back of the neck start to get activated. There's also ones that are equal weight the whole way around the head. Yep. So we just try to target a very specific, how can we get your neck starting to fire in a way that's creating a better curve? Because if you're here in office, I take a picture of you on DMX with the weights on, and then check your blood flow to make sure the blood flow is improving, to make sure the curvature is improving. And third, but most important, that you feel okay or better when using and after using.
Right.
So yeah, that's kind of
that's genius.
Gist of it.
Yeah.
What's that?
Wow.
Yeah.
That's genius.
Thank you.
You haven't told me about that before. What is it? Halo Hutcheson? What did you call it?
Halo Hutcheson harness.
Halo Hutcheson harness. I like it. Is it available on Amazon yet?
Not yet, because I have to make it so 100% of the time that it opens up the jugular vein. So right now it's only really, you should give that under like careful supervision, or if it's coached, because usually, for example, if somebody's lower neck, Dr. Sasha, is already up really tall, but they break in the upper neck, this would be a bad device for them, because what this does is it takes the lower neck and it pulls back up. So if these are already up enough, it's definitely not going to help you. I mean, it's like any therapy can be good or bad. It's just when it's used.
Right.
So yeah, but I'm working on that.
I'm excited to hear about version 2 when it's ready to rock. Wow. Well, thank you so much, man, for taking your time at the end of your workday to after a trip to San Diego, nonetheless, to talk to me about this. And it's really enlightened me as far as the different regenerative things. And I'm going to definitely look into the tendon injections, the dry needling. I think that's is there an association or I guess an educational platform for that, where people get credentialed or certified that might have a practitioner's list or anything like that on there? Or can any physiotherapist or whoever's doing dry needling incorporate that?
I believe anybody that's at least trained a little bit into the tendons can do it. Depends state by state. Check your local legislation. There is no one group that does exclusively tendon dry needling. There are a couple that do teach tendon dry needling. If you look online, there's a few different groups that do include in their curriculum addressing the tendons as well. I recently purchased tendondryneedling.com, so I'll eventually have hopefully a collaborative website of people that do practice it. And just lastly, a little exciting drop. if you'll allow me to, is
Absolutely.
I'm working to develop a software that I just want to share this, that is going to use computer vision, meaning your computer camera, to start to assess some of these deviations in posture. And I think that we'll be able to hopefully build a collaborative around that, where you and I can all use it, and it gives us valuable insight into what our patients are doing, even when they're not at the office, because it can summarize some of the, like, oh, you fell like this 20 times today. Oh,
Yep.
you, so anyway, so that's also an exciting way where I think that it'll help us to see what weights people need, to see what things we can do. So
Exciting.
sorry, I just had to drop a
Yeah,
little.
good
So
for you. I'm glad
more
to hear
exciting
that.
things to come.
We'll have to talk more about that on another occasion. I'm really glad to hear that. So, well, cool. Well, thanks for doing this. Really appreciate your time, and we'll do this again sometime in the near future. Talk a little bit more about your inventions and the software and whatnot.
Thank you, Dr. Sasha. I really appreciate your time as well.
Thanks,
I hope
Brian.
you have a wonderful evening.